Okay, good morning students. Today I'll be taking you through the topic of oral cavity. The normal anatomy will be first told to you, followed by the diseases of the oral cavity. First, the oral cavity, what does it include? It involves the lips, the buccal mucosa, the alveolar margins, also called the gingiva, the retromolar trigone, hard palate, floor of the mouth, and the anterior two-thirds of the tongue. Okay, so these are the main parts in the oral cavity. This is just a revision of your anatomy. What is a retromolar trigone? Retromolar trigone, I have taken it of special interest because subsequently you'll have the involvement of this region, very important. Okay, so what is a retromolar trigone? It is the mucosa on the anterior surface of the ascending ramus, the mandible, behind the last molar, and it is extending superiorly up to the maxillary tuberosity, from the mandible to the maxillary tuberosity. Okay, it's triangular in shape. The base is above, behind the upper third molar, and the apex is below, behind the lower third molar. Now, why is this called the coffin corner? It is called the coffin corner because this is the region where the tendons of the buccinator muscle and also of the superior pharyngeal constrictor muscle almost converge. And also the area, the mucosa on this region is separated from the mandible just with the buccal pad of fat. So you can imagine this is a very crucial point involving major portions such as the cheek, the mandible, and also the pharynx. So any pathology in this region has all propensity to extend to these three regions. Okay, and also any pathology in this region, you will have referred otalgia or referred pain to the ear. That is because of the involvement of the superficial or the sensory branches of the ninth cranial nerve. This is why this is called coffin corner, and it is difficult to diagnose pathology of this region. Also, the anterior fossil pillar is contiguous with this region. So I told you this region is a crucial point where a crux where it is involved, the spread in the pathology in this region causes spread to various regions, various nearby regions. Okay. Also, that's coming to the histology of the oral mucosa. It is lined by stratified squamous epithelium. The epithelium is stratified squamous epithelium. The connective tissue, lamina propria. Now, this stratified squamous epithelium is either keratinized or non-keratinized. It is keratinized in the regions of the hard palate, also on the hard palate, it is also around the gingiva and the dorsal portion of the dorsal part of the tongue. Okay, the dorsum of the tongue. But it is non-keratinized in other regions such as the soft palate, the buccal, the inner part of the cheek, and the inner parts of the lips, and also over the floor of the mouth, the ventral aspect of the tongue. Also, all these regions it is non-keratinized. It is keratinized in certain parts. Okay. Next, I should be dealing with the benign diseases of the oral cavity first. These are all. I have covered the topics that have importance of exam for you. They'll be either given for 4 months or 2 months. So it is a random topic. I'll be covering to you a few topics of those of exam interest and also clinical importance. Okay. Firstly, ranula. Now, rana means a frog. Why is this named ranula? Because a ranula resembles the belly of a frog, and that's why ranula, rana, frog. The belly of the frog. Here I've shown you a picture. The belly of the frog almost resembles, looks similar Ranula looks similar to the belly of a frog. So what is a ranula? It is an extravasation cyst arising from the sublingual gland, or mainly from the sublingual gland. It may also arise from the mucous glands of Nun or glands of Blandine in the floor of the mouth. Okay, so this ranula is in the floor of the mouth. It may arise either from the sublingual glands or the glands of Nun and glands of Blandine. Okay. Occasionally, it may also arise from the submandibular salivary gland. Mostly it is from the sublingual salivary gland, but it may arise from the submandibular salivary gland very rarely. What happens? Firstly, there is a blockage of the duct of the sublingual gland, which causes retention cyst, that is accumulation of saliva in the gland, leading to a retention cyst. Next, this cyst ruptures and the SNI also get ruptured because of increased pressure because of accumulation, leading to an extravasation cyst. So ranula is an extravasation cyst of the saliva from the blocked salivary gland, most commonly sublingual salivary gland. What are the clinical features? As you've seen before also, it presents as a bluish swelling in the floor of the mouth, which is smooth, soft, non-tender. There is no tenderness. It is a cyst, so it has to be fluctuant. It is filled with saliva, so it will be fluctuant. And most important is, it is brilliantly transilluminant. Transillumination test of this cystic swelling is positive. Brilliantly transilluminant swelling in the lateral aspect of the floor of the mouth. It is on the lateral aspect, on one side, either on the left or on the right. I've seen students are not yet logged in completely. They're still coming in. Please see to it that you log into the class on time. Your class starts at 9:45. You're expected to come into the class by 9:45. Okay, so I was talking to you about ranula. Now this ranula may not be confined just to the floor of the mouth, but it may extend into the neck. How? It extends into the submandibular region of the neck through the deeper part of the posterior margin of mylohyoid muscle. So across the mylohyoid muscle, this cystic swelling may extend into the submandibular region. It is then called a plunging ranula. Plunging. This from both it has both intraoral part and the cervical extension. So it is dumbbell shaped. Again, across the mylohyoid, it is cross fluctuant because it is cystic swelling. It has fluctuation. It is cross fluctuant across the mylohyoid and hence bidigitally palpable. Bidigitally, both sides, from the intraoral aspect and also the neck. So this is how it presents clinically. This is a CT picture wherein you see the intraoral aspect and the extension into the neck. This is a plunging ranula. Plunging ranula will be asked to you as a 2-mark question. It is nothing but an extravasation cyst, a ranula that has extended from the intraoral part into the neck across the mylohyoid muscle. It is dumbbell shaped, most important, and it is also bidigitally palpable. It is cross fluctuant across the mylohyoid muscle. See, this is the clinical picture. Brilliantly transilluminant. You should never forget this picture. Ranula is brilliantly transilluminant, located on one side of the floor of the mouth, either right or left. Now, I want you to answer me, what is the duct in relation to this swelling and what is a nerve that could be in relation to this swelling? This will give me an idea of how well your anatomy is. Can someone answer me? Submandibular duct, very good. Yes, submandibular duct or the Watson duct. 030 and 068. They've answered well. Submandibular, yeah, 019, it is submandibular salivary gland duct and the lingual nerve. 019. Chaitanya Swarup. Yeah. So you've answered both the questions correctly. Thank you very much. It is the lingual nerve and the submandibular salivary gland duct, also called the Watson duct. Very good. Thank you. What is the histopathological finding in a ranula? It is a cystic swelling. So it is a true cyst. So it has to be lined by an epithelium. It is a fibrous capsule which is lined by a layer of macrophages. And it contains clear fluid which is nothing but saliva. The retention of saliva causes a retention cyst initially, and this ruptures, it leads to an extravasation cyst. Okay, so as you all told, it may damage the Watten's duct or it may rupture and get infected. What are the complications that can be associated? If it is getting infected, you will have more of neutrophils, eosinophils. Okay, or it may also interfere with speech and swallowing occasionally because it is situated on the floor of the mouth. It can interfere with proper speech. There is no complete difficulty in speaking, but there is no proper speech and swallowing difficulty. Okay. This is the mucous extravasation cyst lined by fibrous connective tissue, fibrous capsule, and a layer of macrophages. Also lymphocytes, plasma cells, and eosinophils. And the cyst contains clear fluid or saliva. So what is the treatment? Important again. Initially, marsupialization. What is marsupialization? I hope you all know what is a marsupial. It is the young one of a kangaroo. How does that feed? How does it grow? It is lodged in a pouch on the abdomen of the mother. That's called a marsupial pouch. So just like that, just like a marsupial pouch, here we try to make the swelling into a marsupial pouch by initially giving an incision on the roof, slit open the cyst and suture the edges of the cyst to the surrounding structure, surrounding layer, such that the cyst is left open for drainage continuously. There is no more accumulation and retention. So initially it has to be marsupialized until the contents are all cleared off. It is left for some certain time, and then once the wall of this so formed ranula gets thickened, then we can easily excise the complete cyst along with its wall. Always remember, a cystic swelling should be excised in toto with the wall to prevent recurrence. So initially marsupialization, and once this is how marsupialization is done, that is the free edges of the cyst along is sutured to the surrounding structures and the cyst is left open, it is de-roofed. Now once the wall of this ranula is thickened, then we can excise it later on. If it is a small ranula, there's a different scene wherein you can directly excise the ranula without marsupialization. Sometimes, since you all know that this ranula has a connection to the sublingual saliva, is arising from the sublingual gland most commonly, this gland itself has to be removed. Okay, so excision of sublingual salivary gland is often needed. Again, important. What is the differential diagnosis? There are two differential diagnoses for a ranula. It is either a lymph cyst or a sublingual dermoid. These topics I will be dealing with in the coming classes also. For today, I will be talking to you. The next topic will be on sublingual dermoid. Just remember this picture of a sublingual dermoid. This picture itself will tell you the difference between the sublingual dermoid and a ranula. Okay. So coming to the next topic, again a sublingual dermoid can be asked to you as a 4-mark question. So what is a sublingual dermoid? Dermoid is a cyst. So these are sequestration dermoids that are lined by, this is true cysts. So they are lined by squamous epithelium containing keratin. The squamous epithelium contains keratin. So obviously this cyst has a thicker wall in comparison to ranula. And most important, this is congenital. It is not acquired. It is congenital, arising in this floor of the mouth present since birth. It is congenital. More commonly, they are always midline swellings. Mostly they are midline swellings, unlike a ranula, which is situated on the either right or left side of the floor of the mouth. Okay, but this is a midline swelling. Again, these are cystic swellings. They are smooth, they are soft, fluctuant again because it's a cyst, but they are non-transilluminant. Again, a differentiating feature from a ranula. They are not transilluminant because it is sequestration. It does not contain a clear fluid. It may be an opaque material inside. So it is not transilluminant. And also importantly, they attain large sizes, again with an extension into the submental region. Midline, so submental region. Because of its huge size, they may cause pain. Unlike ranula, which is a painless swelling, they may cause pain, trismus, dysphagia, or dinophagia. So, as I talk to you, you can always note down the differentiating features between a ranula and a sublingual dermoid, which is a differential diagnosis for ranula, usually. Now, there are two types of sublingual dermoids. One is median and one is lateral. Median sublingual dermoid, it is derived from epithelial cell rests at the level of fusion of the two mandibular arches. Okay, so it may be supramylohyoid or inframylohyoid in relation to the mylohyoid, located between the two genial muscles in relation to the mylohyoid muscles. So the median one is in relation to the mylohyoid muscles in between the two genial muscles on either side of both the sides. Okay. It is always a midline swelling. The median sublingual dermoid is a midline swelling, which is smooth, soft, cystic, sometimes non-tender and non-transilluminant. Now, how do you treat this? Again, excision through oral approach. Incision is given on the floor of the mouth over the swelling, and the cyst is excised in toto. What are the complications? There can be an abscess formation in a sublingual dermoid. Now, this lateral sublingual dermoid on either sides, as the name suggests, it develops in relation to the submandibular duct from the first brachial arch in relation to the lingual nerve and the stylohyoid ligament. It forms a swelling in the lateral aspect of the floor of the mouth. It is usually a smaller swelling, and it could be removed perorally through with an incision on the swelling intraorally. But if it is a large one, then we have to give an incision on the neck in the submandibular region on whichever side it is present. These lateral sublingual dermoids are quite rare in occurrence. So this is in relation to the mylohyoid muscle. If it is large, then it is external surgical approach through the neck, below the genioglossus muscle and above the mylohyoid muscle. Again, a differential diagnosis for sublingual dermoid. It could be a hemangioma, lymphangioma, or Ludwig's angina if it is having an cervical extension. Coming to the next topics, stomatitis. What is stomatitis? It is inflammation of the oral mucosa, either by trauma or radiotherapy, or with the help or because of chemicals or nutritional deficiency or just infection. So stomatitis, itis is nothing but inflammation of the oral mucosa, either because of trauma or deficiency, nutritional deficiency, or because of external chemicals, radiotherapy, or infection. There are various types of stomatitis. I shall be dealing with you a few of the important types of stomatitis. First one is traumatic stomatitis. As the name suggests, it is because of trauma. Trauma by presence of dentures or simple teeth bite or brushing of teeth harshly. Traumatic stomatitis is caused. It presents as painful thin covering of fur, and there is increased salivation. So just the causating factor, if it is removed, and a proper mouthwash will simply cure the condition. Yes, because of dentures, teeth bite, or brushing of teeth harshly. There is increased salivation as it is quite painful. Proper mouthwash and also the causative factor when removed will cure the condition. Next, after stomatitis, the one that we mostly encounter, we as the medical professionals, because this is because mainly of they call tension ulcers. They're seen in malnutrition also, and also in debility and steroid use, excess use of steroids also. You see aphthous ulcers. Normally, even when we people go under stress, we do have aphthous ulcers. Okay. So what are these? They are very painful ulcers, initially formed as vesicles that later rupture and form a deep round ulcer, hyperemic. The edges are more red, hyperemic. The edges of the ulcer are hyperemic, and usually they are multiple. They just not confined one or two, they are multiple. How is this treated? Again, a proper mouthwash and oral hygiene. You may or may not use antibiotics. If it is infected, you can secondarily infected, you have to use antibiotics. A simple application of local anesthetics over the ulcer will solve the problem. Also, supplement with riboflavin. Vitamin B and C helps in healing of the ulcer. So we usually prescribe riboflavin 10 mg tablets. The recurrent aphthous ulcers or aphthous stomatitis with ulcers is often familial. It's more common in women and common in the lip. Also seen in the cheek, on the tongue, which are very painful, and obviously when there is more pain, there is more salivation. They usually heal spontaneously, but during an active period, it will definitely interfere with speech and swallowing. Next comes the topic of Candida stomatitis, or also called Munilial thrush. Now, what is the causative organism? It is Candida albicans. It is a fungal infection, Candida albicans. It is usually seen in immunocompromised patients or immunosuppressed patients, such as the diabetics or individuals who are on steroid therapy or long-term antibiotics, and patients who are bedridden and are prolonged ICU care. Debilitated patients. It may be seen even in infants. Initially, there are multiple red spots which are painful, such pain that they cause difficulty in swallowing also. Initially, they appear on the tongue and the buccal region, which later they turn into curdy white patches. The initial red spots turn into curdy white patches. See here on the soft palate and the fossil pillars, the tongue, the uvula, all this is involved. It is extensive infection, candidal infection, initially arising on the tongue, also on the buccal mucosa, and spreads. It spreads as far as into the pharynx and esophagus, causing dysphagia, difficulty in swallowing. Now, what is the treatment? Obviously, simple application of antifungals like clotrimazole or fluconazole will heal, provided you have to improve the immunity of such patients or stop steroids. And even long-term antibiotics, when used, they may cause increase in candidal infections. So avoid such circumstances. Next, Vincent's ulcerative stomatitis, also called Vincent's angina or trench mouth. Trench mouth is a 4-mark question for you. So what is the causative organism? It is gram-negative anaerobic bacteria, Borrelia vincenti, and the Bacillus fusiformis. It is common in adolescents, young adults below 35 years of age. Now, the patient presents with fever, excessive salivation. They have red swollen gums. The gums are red and swollen, the gingival margin, with a painful ulcer. Have this ulcer scarred infection or not? It depends. The ulcer, somebody 0109 has asked me whether an aphthous ulcer gets infected. How do we know? A simple aphthous ulcers, initially it has a clear base. The ulcer has a clear base. When it is infected secondarily, there is severe increase in pain. Also, the base is covered with slough, increased slough. Okay, and the pain, the hyperemic margin is also increased, and there is associated, obviously, slight increase in temperature. The signs of inflammation are increased. So then we know that it is infected aphthous ulcers. That is when we have to administer antibiotics. Okay. Okay. Let's reserve the doubts for the end of the class. Yeah. Okay, that's okay. Let's reserve the doubts for the end of the class, because I feel that this topic is quite big and I don't want to leave any even small topics, whether they be asked in question in your exam or not. So I want to cover the maximum topics in this in the oral cavity. Maybe I might be a little fast. You may warn me then. But otherwise, let's reserve the doubts for the end of the class, okay? It's because you don't follow, just put your doubts on a paper and ask me at the end of the class, okay? Number 109, I'll be now following to the present topic of Vincent's angina, also called trench mouth, okay? So the patient here presents with fever. They have excessive salivation, obviously, and most important, the gums. Initially, the gums, the gingiva is involved, so it presents as a red, swollen gums with painful ulcers over the gum. And important, again, a yellow slough, which is easily removed like a membrane. Hence, it is called a pseudomembrane. It is a pseudomembrane. It is formed by the slough of necrotic tissue covering the ulcer. So, it is called a pseudomembrane. It is easily removed. Hence, this is also called Vincent's ulcerative stomatitis. It is ulcerative gingivitis. There is acute necrosis of the tissue involved. So, it is a very dreaded disease wherein there is necrotic ulcerative gingivitis initially, and from the gums, it may spread to the cheek, the palate, and pharynx also. Usually, the tongue is not involved in Vincent's angina or the trench mouth. Okay. Next, important again, since it is an extensive disease, there is definitely involvement of the regional neck cervical lymph nodes. They are palpable. They may be tender. Again, important, fetor oris or musty smell from the mouth is quite typical. Since it is, I told you, this is a disease of the gums, usually edentulous patients will not have this infection. Now, when this infection has involved the tonsillar crypts, then it is called Vincent's angina. Okay. This is usually seen in smokers and also in patients who are under severe forms of stress. The hallmark of Vincent's angina is necrosis and cratering of the interproximal papilla. That's why it is also called punched out papilla. There is the papilla are, there is a crater formation. The ulcers are so deep that there is almost a crater formation in the interproximal papilla. Hence, it is also called, there is also presence of punched out papilla appearance histologically. Okay. Now, how do you confirm or diagnose this condition? It is with swab culture over the affected area, the ulcerated region, wherein you get to culture the involved organism, Borrelia vincenti. Now, treatment is with antibiotics, penicillin group, and also I told you the membrane can be peeled off. And again, proper mouthwash and supportive measures, supplementation with vitamins like B and C will help cure the condition. Next condition is nutritional stomatitis. As the name suggests, nutritional because of deficiency of certain nutritional factors like vitamin B, more common, like nicotinic acid deficiency, pellagra, or riboflavin deficiency, there is stomatitis, commonly in the tongue. It presents as red area with atrophy of the papillae in the involved region of the tongue. Vitamin C deficiency is commonly seen as bleeding gums and loosening of teeth. Iron deficiency anemia causes superficial glossitis, mainly in females. How do you treat these nutritional stomatitis conditions? Just supplement the deficient vitamins. Vitamin B, B complex. More commonly it is nicotinic acid and riboflavin. Next, vitamin C supplementation, and iron and folic acid. Next topic is angular stomatitis, also called angular chelosis or bell ache. What is this? It is a superficial, lengthy, red-brown fissures or ulcers in and around the angle of the mouth. They are superficial, lengthy, red or brown in color, ulcers or fissures. Initially they start as fissures and then they ulcerate around the angle of the mouth with cracks. Commonly, because of candidal infections or simple streptococcal infections, they may cause angular stomatitis. It is again treated with supplementation of vitamins B and C, iron and protein, provided with a good oral hygiene. Bell ache is also seen in infants who have a habit of suckling their thumbs. So bell ache is common in infants suckling who have habit of suckling their thumbs. It is common. You need not worry then. Again, important topic, cancrum oris, also called noma. Cancrum oris, it's noma. It's called noma because noma means to devour, to eat greedily. To eat greedily in Greek. There is extensive destruction. It is an infective gangrene, a severe form of Vincent's acute ulcerative gingivitis. I told you Vincent's stomatitis or gingivitis initially is ulcerative, and then when there is severity of infection, there is also necrosis. But when this necrosis is extending severely, it is called cancrum oris. So this is a secondary infection, secondary condition after Vincent's angina or stomatitis. What are the predisposing factors to cause noma? Mainly malnourished children, a severely sick child. There is uninterrupted spread of Borrelia vincenti and fusiformis bacteria infection that leads to extensive infectious gangrene of the oral cavity. Firstly, it starts in the lips and then spreads to the cheek, the bone, or either maxilla or mandible, soft tissues, and the skin, and finally onto the skin also. So remember this picture. It starts in the lips, later it extends to the gums and spreads to the cheek, the bone, the soft tissue, and also the skin covering it. There is extensive tissue loss. And there is severe toxemia. So patient is severely toxic, is already malnourished, and there is severe toxemia. Extensive necrosis of the mucous membrane of the oral cavity with destruction of deeper soft tissue and often bone. So remember, it involves the bone also. Obviously, to look at, you have a differential diagnosis of carcinoma. But remember, carcinoma spreads, proliferates. There is proliferation also. But in noma or cancrum oris, there is no proliferation of the involved tissue. Okay. If it is in children, it may follow after an attack of measles, gastroenteritis, typhoid, or bronchopneumonia. As you can see, all these four conditions will cause the decrease in immunity. Okay. Predisposing factor, as I already told you, is malnourishment. There is excessive salivation, difficulty in swallowing, and fetid odor because of the infection. With destruction. Destruction is very important. There is discharge and toxic features. And the patient has systemic toxicity. Again, how do you diagnose this condition? Take a swab from the involved area and you can confirm the presence of Borrelia vincenti organism. Take an X-ray of the involved region, you get to see the involvement of the bone and there is destruction. There may be secondary infections also. This is usually seen in sub-Saharan countries and underdeveloped countries. It has got a very high mortality. Remember, you can always halt the progression of this disease. Although you cannot repair or you cannot bring back the normal tissues that have already been destructed, but you can always halt the progression of the disease, limit the progression of the disease. Unlike in carcinoma, how when you give proper treatment, proper and timely treatment, recognize the condition as early as possible, even before it involves the bone and the skin, overlying skin. So once it has become toxic, you'll have to give systemic antibiotics and high-dose penicillins with anaerobic coverage with metronidazole, supplement, improve the nutritional status of the patient, give high proteins and vitamin-rich diet. Since it's not able to swallow, you have to do it through a nasogastric tube. Clean the wound, irrigate it properly, and once you have cleaned it, obviously you have to excise the dead tissue. You may also have to give a blood transfusion or a total parenteral nutrition. Once you have stabilized the condition of the patient, the general condition of the patient, then you can go for coverage of the defect. I told you, you can halt the disease, but you can never reverse the condition. So once it has been destructed, you will have to do a repair surgery, a maxillofacial facial surgery or a plastic surgery to repair the defect. This is one such patient who has been managed. The progression of the disease was stopped with appropriate antibiotics, systemic toxicity control, wound properly managed, and later once it is found to be healthy, it was covered with a flap, muscocutaneous flap. Next, syphilitic lesions of the oral cavity. The various headings. It could be a canker in the lips, which is highly contagious, primary chancre. It presents as a painless swelling anywhere, just like an ulcer, syphilitic ulcer anywhere. First, initially there's a macule formation, which is painless, and later it becomes an ulcer, and it has a pain then. Ulcer eventually heals with a scar. Most commonly, it occurs on the lower lips, maybe on both upper and lower lips. This is a primary syphilis. Also, the other presentation is mucus patches, which are grayish-white contagious patches, usually seen on the lip, also on cheek and the fauces, which fuse together to form linear snail track ulcers. Very important, linear snail track ulcers in the fauces or on the pillars. Faucial pillars. This is a form of secondary syphilis. Now, Hutchinson's contagious condyloma in midline tongue can also occur. Other representation is agammatous painless ulcers. These are painless ulcers seen on the anterior 2/3 of the tongue or the palate, the hard palate and the nasal septum. They cause perforation and collapse of the nasal bridge. This is quite known to you, already covered in your previous subjects. Syphilitic chronic glossitis, it is seen in tertiary syphilis, which is a precancerous condition. Now, coming to the other important topic in the oral cavity is leukoplakia. Again, this can be asked to you as a 4-mark question. What is leukoplakia? It is a white patch in the mucosa which cannot be characterized or categorized clinically or pathologically into any other condition. So this is a white patch in the mucosa. The other conditions that also resemble a leukoplakia but have a different cause will be which are not categorized under those conditions. That is leukoplakia. It is potentially a premalignant condition. So what are the common causes that leads to causation of leukoplakia? excessive of any of these. It is not just smoking or smoke spirit, it is excessive of these conditions, these ecological factors. Smoking, remember I have written, when I have depicted this to you to show the importance of, to let you remember the mnemonic, the 6 S's it's actually called. Smoking, spirit or alcohol. Instead of telling alcohol, you better remember it is spirit, so that the 6 S's that are the causative factors of any conditions in the oral cavity. Even if you forget this condition in particular, you can always mention the 6 S's for all the pre-malignant conditions and the malignancy in the oral cavity. Smoking, spirit or alcohol, sepsis, infection, superficial glossitis, syphilis, spices, sharp tooth. Okay, so these are the 6 S's. Susceptibility, the predisposing condition on the oral cavity that can cause leukoplakia. Increased palm chewing using areca, tobacco or slaked lime, the calcium carbonate that is kept for longer duration in the mouth. Slaked lime. Next, chronic hypertrophic candidiasis, or it's nothing but monilial thrush, which is extensive, severe and not responding to simple antifungals. Long-standing candida infection. Now, there are 3 types of leukoplakia. One is homogeneous, simple, extensive spread, homogeneous or nodular. You can see the nodule formation, nodular white patches, painless white patches, and speckled white patches on the oral mucosa. Now, this speckled and the nodular varieties, these are potentially premalignant. Somewhat safer is homogeneous leukoplakia. How does the lesion appear? It appears as a white or grayish colored, well localized patch. It is localized with well defined margins, either in the cheek or tongue, palate, or in the other areas. Okay, so it is well defined margins, either homogeneous or nodular or speckled. Important to note the figures. Incidence of leukoplakia in those who smoke or chew pan is 20%. There is a high predisposing factor, smoking and chewing pan. Incidence in non-smokers is just 1%. Now, incidence of this leukoplakia turning into malignancy is as much as 2 to 4%. This propensity increases with age and duration of the pan chewing and smoking. The duration, longer the duration, I told you, it is consistent. When these causative factors are consistent, then there is occurrence of leukoplakia. So obviously the duration of pan chewing and smoking is also important for it to turn into malignancy. Leukoplakia is more commonly seen on the buccal mucosa and the commissures, although it is always seen in the other areas of the oral cavity also. It is common in males as much as 3:1. Male to female ratio is 3:1. Leukoplakia with the maximum propensity to turn malignant is of these following conditions. It is seen in the elderly, the long duration leukoplakia with the increased causative factors. It is seen in elderly and young females. In the floor, if it is there in the floor of the mouth, leukoplakia, when it is present on the floor of the mouth and on the tongue, then it is more prone to turn into malignant. If the well-defined white patches when they are indurated. Induration is again an important feature for malignancy. Induration, cracks and fissures when seen, it has higher malignancy potential. Now, what is the histological finding? That is parakeratosis with widening of retipex. Now, what is this parakeratosis? It is the increased accumulation of the keratin layer of the stratified squamous epithelium lining the oral mucosa. When there is increased keratin formation, how is it seen? By increased nuclear coilocytes. Okay. The normal basement, I told you the oral cavity has a normal basement membrane, the basal layer, the spinosum, the granulosum, and the topmost corneum layer. When this corneum layer proliferates excessively, then you see hyperkeratosis or parakeratosis. The hyperkeratosis is of two kinds, either orthotic or parotic. So parakeratosis is more common, and also there is widening of rete ridges. What are these rete ridges or rete pegs? They are nothing but extension of the inward extension of the epithelium into the connective tissue. These rete ridges, when they are widened. Now, biopsy you should always do to diagnose and also rule out carcinoma. How is carcinoma? Again, there is dysplasia, then you will have to, I'll tell you subsequently. So, biopsy is always important in leukoplakia. It confirms the diagnosis and also rules out carcinoma. The different types of leukoplakia. When there is in thin, smooth leukoplakia, there is hyperkeratosis and acanthosis, occasional lymphocytes. Again, when I told you fissured and cracks, that is, it has dysplasia, mild to moderate degree of dysplasia. Now, verruciform or granular leukoplakia, there is also a bulbous rete ridges, severe dysplasia, moderate to severe dysplasia, and associated congested vessels with infection, secondary infection with candida. Now, erythroleukoplakia is also called speckled leukoplakia. This is highly potentially malignant, and there is severe dysplasia, carcinoma in situ. Also presence of carcinoma in situ. Okay, this picture is just for you to remember well. Now, histological staging of leukoplakia is very important. Depending upon the stages, it can be classified as malignancy. Initially, there is just acanthosis, that is the elongation of rete pegs. These are the rete pegs, elongation, widening. A smooth white dry patch, just present a smooth white dry patch. Next, associated parakeratosis, that is increased keratin layer. Again, thicker white patches are seen. Next comes the widening of rete pegs. Next, there is dyskeratosis, where the keratin cell formation deep to the epidermis is irregular, dyskeratosis. Next, there is dysplasia, premalignant. Next, carcinoma in situ. So this is how the leukoplakia progresses histologically to carcinoma. Leukoplakia is potentially premalignant condition. How do you treat leukoplakia? Stop the causative factors like pan chewing and smoking. If you can do it, excise the involved area and then cover it with the skin grafting. Regular follow-up is necessary to rule out the formation or the occurrence of carcinoma in situ and carcinoma. There is also documented evidence of usage of isoretinoin, beta-carotene, tocopherol in leukoplakia with good results. Carbon dioxide laser excision of the involved area is also done. Another important topic for you in this context is hairy leukoplakia. Here, hairy leukoplakia, it is asymptomatic white lesions of the oral cavity, and the causative organism is EB virus, Ebola virus. The most common site is tongue, the margins of the tongue, on the lateral margins of the tongue. Also may occur on the dorsal surface of the tongue and the buccal mucosa. Floor of the mouth also may be involved. This hairy leukoplakia is very important in the context of immunocompromised conditions, commonly seen in HIV also. Again, histologically, it is the same: hyperkeratosis, increased hyperkeratosis, and there's demonstration of EB virus, either in situ or PCR method or through southern blot methods, ELISA. The treatment here is simple antiretroviral therapy. Next most important topic is erythroplakia. It is a red velvety appearance of the mucosa of the oral cavity, again which cannot be categorized into any other causative conditions. Just like leukoplakia, the red velvety appearance of the mucosa here is not categorized into any other recognized condition. Now, erythroplakia is more potentially malignant than a leukoplakia, as much as 70 to 20%, 20 times. Erythroplakia is equal in both sexes. Why does this have a red color? Because it is because of decreased keratin here, causing shining and prominence of the submucosal vascularized connective tissue. Beneath the submucosal vascular connective tissue, there is proliferation there and the keratin layer is decreased. Hence, there is this reddish velvety appearance. It is common in the lower alveolar mucosa, the gingivobuccal sulcus, and the floor of the mouth. Again, here also it can be homogeneous or speckled or granular. Another important thing is erythroplakia interspersed with leukoplakia. Okay. The severe epithelial dysplasia is the important factor. See, this is why it is more potential to turn malignant. Epithelial dysplasia is very important. Erythroplakia, you have to mention about epithelial dysplasia. Then diagnosis again done by a biopsy. And the treatment is take a biopsy and surgically excise the lesion. Next, oral submucosal fibrosis. What is oral submucosal fibrosis? It is nothing but a chronic, long duration, debilitating disease of the oral cavity. What happens here? There is initially inflammation, irritation and an inflammation, which later progresses to fibrosis of the submucosal tissue. So the submucosal fibrosis, the name it suggests. It results in marked rigidity and an eventual inability to even open the mouth. That is the high range of fibrosis that occurs. Initially, it is an insidious chronic process which is characterized by dense white patches in the oral cavity and also in the pharynx. There is extra juxtaepithelial deposition of fiber tissue. Now, this is also pre-malignant condition. It is almost accounting to 40% of all the oral cancers. In India, and oral submucosal fibrosis is as much as 5 for every 1,000 cases. It is seen in middle-aged people, more commonly in the females. Now, what are the causes? Again, pan, tobacco chewing, prolonged betel nut chewing. For long duration, they keep the chewed tobacco in the mouth and the corners of the mouth, and they keep chewing it for a prolonged duration. Also, cigarette and bidi smoking with alcohol, spicy food and nutrition deficiency, iron, vitamins A and B, zinc and antioxidants. How is this caused? The pathogenesis. The patient has hypersensitivity to chili, betel nut and tobacco. Also, in presence of vitamin deficiency, there is alteration of collagen metabolism. This causes juxtaepithelial progressive inflammatory fibrosis of the submucosa, also epithelial atrophy and dysplasia. There is epithelial atrophy. In the submucosa, there is progressive inflammation and further fibrosis. Now, what happens? Ericolin, the content in tobacco, stimulates the collagen synthesis. And tannin stabilizes this collagen fibrils and makes them resistant to degradation by collagenase. Hence, there is extensive fibrosis. See here, this is submucosal fibrosis of the right cheek. There are stiff fibrotic bands and also scarring. This is how it is seen. The stage presentation in submucosal fibrosis. Initial stage, there is just stomatitis, wherein there is formation of vesicles ulcerate, there is soreness and burning sensation in the mouth. Here, the patient has a very high intolerance to chilies and spicy foods because they cause irritation of these vesicles or the ulcers. There is burning sensation in the mouth. Initial stomatitis, stage 1. Next, it progresses to fibrotic stage or stage 2, wherein there is white fibrotic bands over the soft palate, the pillars, and the retromolar trigone, the buccal mucosa, and gradually progressive painless trismus, difficulty in opening the mouth. Next, stage 3, the sequelae of this fibrosis. There is marked trismus, ankyloglossia fixata. Obviously, because of this trismus and ankyloglossia, the patient has very poor orodental hygiene and associated leukoplakia, difficulty in speech, and also submandibular swellings, the lymph nodes. This is a clinical picture. There is marked trismus and ankyloglossia. On the inner aspect, you get to see the white patches with fibrotic strands. Diagnosis is clinical. Also, a biopsy after toluidine blue staining will demonstrate the submucosal inflammatory fibrosis. The blood picture, they'll have anemia and increased raised ESR. So what is the treatment for oral submucosal fibrosis? It is medical management and surgical management. Medically, you have to give local steroids, dexamethasone 4 mg along with Hylase to break down the fibrous tissue. 1500 units and 1 ml of intraoral or submucosal fibrous over the fibrous bands. Given once or twice a week for 6 to 8 weeks. This is important medical management of oral submucosal fibrosis. Also, because of malnourished, have to supplement with vitamins and zinc and antioxidants. Improve the oral hygiene. Avoid the irritants. Surgical is, you'll have to excise the fibrotic lesion. So, incision and sectioning of the fibrous bands and then grafting over those regions to provide for mobility. What are the various grafts that are used? Either the skin graft, Thiersch graft, bilateral tongue flaps can be used, nasolabial flaps, temporalis fascia graft, or bilateral radial forearm free grafts may be used over these oral mucosas. Laser excisions, carbon dioxide to cut the fibrotic bands. You may also do relieve the trismus. In advanced cases of trismus, you may also have to do condylectomy. So this is the management of oral submucosal fibrosis. Chronic hypoplastic candidiasis is nothing but extensive oral thrush, monilial thrush. It is common in commissures of the mouth and tongue. There is dense plaque of leukoplakia with curdy white patches. Curdy white patches is diagnostic or pathognomic of candidal infection, Candida albicans infection. It may not respond to drug, surgery, or laser. Always candidal infection is associated with immunodeficiency. So treatment is, now topical may not be sufficient, you'll also have to give systemic antifungal treatments and excision of the involved area, surgical excision or laser therapy of the involved area. So I'll just tell you the list of the premalignant conditions of the oral cavity in this class. As already discussed to you, leukoplakia, erythroplakia, chronic hypoplastic candidiasis, oral submucosal fibrosis, and syphilitic glossitis, hereditary syphilitic glossitis. Other than these, the other conditions, sideropenic dysphagia, whether there is sideropenic anemia, associated dysphagia, oral lichen planus, discoid lupus erythematosus, type of SLE, disc keratosis congenita. So these are the conditions which have potential to turn into malignant conditions in the oral cavity. So this is a list of the premalignant conditions, and the next class I'll be talking to you about the premalignant conditions, a few of them, and we'll go into the oropharyngeal cancers. Okay. So now the session is open to your questions. You may ask your doubts in the topics so far covered. I hope I was not very fast in covering the topics. But since this is a huge topic and I want to cover all the important points to you, I think I was a bit fast. You can always warn me if I'm too fast and you're not able to understand what I'm telling. Okay. Since you're given the topics in advance, I always suggest you go through the topics prior to the class so that there is better understanding of the subject, and you may ask questions whenever you have a doubt. Either nothing has gone to your brains or everything is understood. This is what I understand when you don't ask me doubts. No doubts. So your total strength is 147, right? And I get to see just 128 members, 127, 126 in the class. What happened to the rest? You all feel that these topics are not very important to you. But remember, these topics will not be covered to you again in your final year. So you better make a note of these topics whenever the class is told, either during the class or after the class. Go through the subject matter and make down a note. Okay, so that at the end of your final year, when you get to revise the topics, you'll have a better subject material. These topics are very important to you. Okay, I shall close the session. I presume there are no doubts. You may also ask me doubts in my next class, the coming Monday. Thank you.